Hello everyone. So today I'll be talking about management of anemia and chronic kidney disease. So in CKD patients, anemia is defined using the KDIGO guidelines, that is the Kidney Diseases Improving Global Outcomes guidelines, according to which hemoglobin of less than 13 grams per deciliter in men and hemoglobin of less than 12 grams per deciliter in premenopausal women is defined as anemia, and this definition applies to adults and children beyond 15 years of age. So if you look at the epidemiology and natural history, the incidence and severity of anemia increases progressively with declining kidney function. So hemoglobin level starts to fall at EGFR of less than 75 ml per minute for males and less than 60 ml per minute for females. It starts to fall much earlier in diabetic patients, whereas on the contrary, in patients with polycystic kidney disease, usually they have polycythemia. And if you take all the CKD patients, put together, 50% of the patients with CKD have anemia. So if you see here on the y-axis, you can see the percentage of patients with anemia, and on the right axis, on the x-axis, you can see the stage of CKD. So as the EGFR goes on falling, you can see that the percentage of patients with anemia is gradually increasing. Now, what are the causes for anemia in patients with chronic kidney disease? First and foremost, it is the relative erythropoietin deficiency because of reduced erythropoietin production by the cortical interstitial cells. There are also uremic inhibitors which inhibit the entire process of erythropoiesis. And as we all know, CKD is a condition of chronic inflammation. And whenever there is inflammation, the liver produces a protein called hepcidin. And this hepcidin combines with a protein called ferroportin. So this ferroportin is an export protein which exports iron from the storage sites like the liver, spleen, and the duodenal enterocytes. So what this hepcidin does is it combines with ferroportin and degrades the ferroportin. So because of which although iron is available in the storage sites, it is not available in the circulation. It cannot be transported into the circulation. So that is why there is functional iron deficiency in patients with chronic kidney disease. And as we all know, the lifespan of RBC is 120 days. And in patients with CKD, the lifespan is shortened because of intravascular hemolysis, again because of uremic toxins, and extravascular hemolysis. This is in dialysis patients who are exposed to extracorporeal circuit. Again, as I already mentioned, CKD is a stage of chronic inflammation because of which there is increase in levels of hepcidin and also reduced erythropoietin receptors. On an average, a dialysis patient loses approximately 2 to 3 liters of blood in 1 year. And also, we have to get the blood test done for the dialysis patients every month. And so there is multiple venipunctures that is happening. So that also adds to blood loss. CKD patients are again immunocompromised and they are prone for infections, most commonly catheter-related bloodstream infections, lower respiratory tract infections, and some of these CKD patients are obviously diabetic because diabetes is the most common cause of CKD, and they have leg wounds, non-healing ulcers, and so on. So all these chronic infections like osteomyelitis and so on, they add to cytokine storm, which again impairs erythropoiesis. Uremia reduces appetite, causes fatigue. Patients feel patients have nausea and vomiting. So because of which they're unable to take enough nutrients like iron, vitamin B12, folic acid, and also there is gut edema. So the absorption is hampered. CKD is a condition of secondary hyperparathyroidism which can progress to tertiary hyperparathyroidism, leading to bone marrow suppression. And as you all know, RBCs are produced by the bone marrow. So this is how normal erythropoiesis happens. We have the hematopoietic stem cell progressing to burst forming unit, colony forming unit, proerythroblast, early erythroblast, rate erythroblast, which includes polarization of the nucleus. Following that, there is reticulocyte formation, and finally RBCs, where the enucleation takes place. So if you see here, the transferrin receptors are highest expressed in late erythroblast and reticulocyte stages. So this is when the transferrin receptor 1 is activated, and it takes in iron from the circulation for production of hemoglobin. And in the final stage, there is alpha globin and beta globin, which combines to form hemoglobin inside the RBCs. So why should we worry about the anemia in CKD? Why should we learn so much about anemia in CKD? Why should we even bother treating? So it is because of this. There are certain dire consequences of anemia in CKD. The cardiovascular related mortality is 15 times more in CKD patients. 50% of deaths in patients with CKD is because of cardiovascular disease. Left ventricular hypertrophy is the most common abnormality seen in patients with chronic kidney disease. Tissue hypoxia because of anemia is supposed to be the principal stimulus triggering the compensatory changes in the cardiovascular system. And studies have proven time and again that there is a strong correlation between anemia and left ventricular hypertrophy. So now, as we all know, the most common cause for CKD is diabetes mellitus followed by hypertension. So these are again independent risk factors for cardiovascular disease. So generation of hypoxia because of anemia is poorly tolerated in patients with pre-existing cardiac disease as well. And some studies, especially the intervention studies like the DOPS, has shown that for every increase of 1 gram in deciliter of hemoglobin, there is a drop in mortality by 4%. And also, if someone is in CKD stage 2 or 3 and if he develops anemia, the rate of progression or worsening of renal dysfunction is much higher because of hypoxia. Anemia also increases the risk of bacteremia. There is 11% increased risk for every 1 gram per deciliter fall in hemoglobin. It also has detrimental effects on the brain and the cognitive function, finally ultimately leading to poor quality of life. So now coming to the diagnostic workup, so this is what we have to ask for. Complete blood count with peripheral smear. Usually it is normocytic normochromic anemia in patients with chronic kidney disease. Red blood cell indices, reticulocyte count, iron profile, test for occult GI bleed, vitamin B12, folic acid levels, parathyroid hormone levels. Sometimes the cause of anemia can be other than erythropoietin deficiency, and it should be ruled out, especially when the severity of anemia is disproportionate to the loss of kidney function, and if there is an evidence of iron deficiency. Also, if there is associated thrombocytopenia and leukopenia, that is if there is pancytopenia, then you have to look at other causes. Coming to serum iron means basically it is the ferric iron which is being measured, and it is subject to diurnal variations. The ferric iron levels are higher during the morning hours compared to the evening hours. This is because of the circadian rhythm where the hepcidin production is least in the morning. Total iron binding capacity measures the amount of iron binding sites available on serum transferrin. Transferrin saturation generally reflects iron available for transport to the bone marrow. So this is calculated as serum iron divided by total iron binding capacity into 100. Serum ferritin reflects the stored iron, but it may not be accurate all the time because it also acts as an acute phase reactant and can be elevated in acute and chronic inflammatory states. So this is the normal cycle of iron. So usually in our diet we consume 10 to 20 milligrams of iron, out of which 1 to 2 milligrams is absorbed in the small intestine. So it is transported in the circulation where it is bound to transferrin. 75% of iron goes to the bone or the bone marrow where hemoglobin production and erythropoiesis is happening. 10 to 20% of it is stored in the liver, spleen, and bone marrow as ferritin. 5 to 15% of it is utilized in other processes such as formation of myoglobin, cytochromes, and other enzymes. 1 to 2 mg is lost because of desquamation of the epithelial cells of the GI tract and the skin. So hepcidin is considered the master regulator of iron. You can see that in states of inflammation, like in CKD, the liver produces a protein called hepcidin, and this hepcidin combines with ferroprotein, which is an export protein, and degrades the ferroprotein. So because of which the iron gets locked in the storage sites. That is, the iron is locked in the duodenum, the liver, the spleen, and other reticuloendothelial organs, and it is not available in the circulation. So the conditions which cause upregulation of hepcidin are inflammation, infection, and iron overload. The conditions which cause downregulation of hepcidin are hypoxia, iron deficiency, and erythropoiesis. So as I mentioned, ferritin is levels are low in iron deficiency. It is normal in anemia of chronic disease because it is an acute phase reactant, and whenever there is acute illness, acute infection, or a chronic inflammatory state, the levels of ferritin tends to rise, and it is also increased in states of iron overload. Coming to serum iron, transferrin, and transferrin saturation, these are sensitive to diurnal variations and to dietary intake. The levels are much higher during the early morning because the hepcidin levels are low, as I already mentioned. Serum transferrin can be elevated by the use of OCPs, and it is reduced with inflammation or infection. Serum transferrin and TIBC are dual markers because they are not just markers of iron status but also of nutritional status and protein balance. A lower baseline total iron binding capacity or its decrease over time in patients who are on dialysis is suggestive of protein energy malnutrition, and such patients are at increased risk for mortality. Coming to serum transferrin receptor, these are shed from the membrane of the maturing erythroblasts and reticulocytes, either in soluble form or as vesicles. So the concentration is elevated in iron deficiency. It basically expresses the size of the pool of maturing erythroblasts, and it is not affected by inflammation. Hypochromic RBCs, they are defined as the percentage of erythrocytes with mean corpuscular hemoglobin concentration of less than 28 grams per deciliter, measured by automated analyzer. It is a very sensitive and early indicator of iron deficiency and also an independent mortality predictor compared to all other iron parameters. If the values are higher than 6%, then the patient is having iron deficiency and is most likely to respond to IV iron therapy. So the blood sample should be processed within 4 hours for measuring percentage of hypochromic RBCs. Coming to reticulocyte hemoglobin content, this is also one of the sensitive indicators of functional iron deficiency. So a combination of percentage of hypochromic RBCs greater than 6% and the reticulocyte hemoglobin content of less than 29 picograms per cell has shown to be the best diagnostic tool for iron deficiency based on the hemoglobin response to IV iron. Bone marrow iron, this is the gold standard method for assessing iron stores. So we use the Pearl's Prussian blue stain to detect and assess the iron in the bone marrow, especially in the form of ferritin and hemosiderin, which is stored within the macrophages. But studies have shown that it is no better than TSAT or ferritin in correctly identifying responders to iron therapy. As you all know, bone marrow examination is very cumbersome and a painful procedure, and the values are not, the results are not going to yield anything great or any extra information. So we are not doing it on a routine basis. Coming to liver MRI, this is used for assessment of iron overload disorder. So surprisingly, in France, one of the dialysis centers conducted a study on their dialysis patients, 119 dialysis patients, where they just did liver MRI to find out the iron overload, and they found that 80% of that patients had mild to moderate iron overload, and approximately 30% of them had severe iron overload. So yeah, it is not very uncommon. We're not doing liver MRI regularly in our patients, but iron overload is definitely not an uncommon scenario. Iron therapy, ferrous iron is more easily absorbed compared to ferric iron. So how do we calculate the total iron dose? We use the Gansoni equation, that is actual body weight into target hemoglobin minus the actual hemoglobin into 2.4 plus 500 for the iron stores. So what is absolute iron deficiency and functional iron deficiency? Absolute iron deficiency is when the iron levels in the storage form is also low and iron available in the circulation is also low. Whereas in functional iron deficiency, the storage, the ferritin levels or the storage form of iron is adequate, but the iron is not available in circulation. So this happens when the hepcidin levels are high in the body. So coming to the parameters for definition, T-sat of less than 20%, ferritin of less than 100. In CKD patients who are not on dialysis is considered to be absolute iron deficiency. For functional iron deficiency, we take a T-sat of less than 20% again, but ferritin of less than 500. And the target hemoglobin is in CKD patients who are not on dialysis is 10 grams per deciliter. In patients who are on dialysis, T-sat of less than 20% and ferritin of less than 200 is suggestive of absolute iron deficiency. For functional iron deficiency, it remains the same. T-sat of less than 20% and ferritin of less than 500. Target hemoglobin in patients who are on dialysis is between 10 to 11.5 grams per deciliter. So there are various iron formulations, oral iron formulations that are available. So you can see here that there are some traditional oral iron formulations and novel oral iron formulations. The traditional ones are ferrous sulfate, ferrous fumarate, ferrous gluconate. 325 milligrams of ferrous sulfate has 65 milligrams of elemental iron. So approximately you need 200 milligrams of elemental iron per day. So that would mean that you have to prescribe 3 tablets of elemental iron per day. And if you look at ferrous gluconate, the number of tablets is even much higher. It is 5 tablets per day. So this is the problem with traditional oral iron formulations, because the percentage of elemental iron is much lower. We have to prescribe higher number of tablets, and they are associated with GI side effects, anorexia, nausea, vomiting, and so on. And so now we have novel oral iron formulations such as ferric citrate, ferric maltol, liposomal iron, and sucrosomal iron. Ferric citrate was initially prescribed for binding phosphorus. It was supposed to bring down the levels of phosphorus, and later on they identified that okay, this helps in treating iron deficiency as well. So as you can see here, the tablet is 1 gram and it has 210 milligrams of elemental iron. This is only 65 milligrams, but this one tablet has 210 milligrams of elemental iron. We also have ferric maltol, which is both lipophilic and hydrophilic, so the absorption is much better, bioavailability is much better. And liposomal iron is ferric pyrophosphate surrounded by a phospholipid bilayer. So as you can see, only 1 tablet per day is sufficient, and GI side effects are also less. Similarly, sucrosomal iron as well. So all these formulations have lesser GI side effects, but unfortunately they are more expensive, and also the number of tablets that are required per day is very less. So because of that, the adherence is much higher among patients. So the pros and cons of oral iron. For oral iron, obviously you don't require any IV access. It is inexpensive compared to IV iron formulations. It is convenient to take, and it utilizes a normal iron physiology. Coming to the cons, GI adverse effects, poor tolerability and adherence because of the number of tablets that are required to be taken per day. Sometimes food, calcium supplements, and antacids reduces iron absorption because you need a gastric pH of in the acidic range to improve absorption of iron. And the iron levels increase very slowly with oral iron. And if there is any GI bleeding, it might be masked because of the blackish discoloration of stools in patients who are taking oral iron tablets. Now, coming to IV formulations, we have older traditional IV preparations and the novel iron preparations. The older traditional ones are iron dextrin, iron sucrose, and ferric gluconate. So, if you look at iron dextrin, that was supposed to be the one which had highest anaphylaxis. It was notorious to cause anaphylaxis and even deaths. So, test dose is a must before giving iron dextrin. In fact, all formulations of IV iron, not just the older traditional ones, but even the novel ones, are known to cause anaphylaxis. But the percentage of anaphylaxis in the novel iron preparations is less than 0.5%. So, the older traditional preparations such as iron sucrose, so this is bound to a carbohydrate moiety. So when you give IV injection of iron sucrose, the carbohydrate moiety immediately dissociates from the active iron, and the active iron is released into the circulation. So this active iron is actually toxic to the body, causes free radical injury. It destabilizes the cholesterol plaques or atherosclerotic plaques in the blood vessels, can cause cardiovascular mortality. It increases the cardiovascular mortality very much so. And that is the problem with iron sucrose, and that is why we can't give high doses of iron, elemental iron in iron sucrose. We have to give little minute amounts of iron. So if you see here, the maximum single dose is only 200 milligrams, and you will have to give 5 doses of 200 milligrams over 5 weeks to cover up for the loss of iron stores, loss of iron, to treat iron deficiency anemia basically. Similarly, if you look at ferric gluconate, it is just 125 milligrams in one single dose, and you have to give 4 doses weekly. 250 milligrams of 4 doses weekly should be given. But when you look at the novel iron preparations, the dose is much higher. You have 750 milligrams, 1 gram of ferric carboxymaltose, and full dose can be given in either 1 or 2 sittings. Similarly, with ferric isomaltoside, 1 gram injection, full dose can be given in just one sitting, and ferromoxidol also full dose can be given in one sitting. So the patients don't have to keep repeatedly coming to the doctor or the clinic for injections. So these are very useful for patients who are not on dialysis. If patients are already on dialysis, they can anyway take it during the dialysis sessions, but otherwise the number of pricks are very much reduced, and also the anaphylactic reactions are lesser. The bioavailability is better, it is more potent. So the novel iron preparations are usually preferred. So the pros of IV iron is that it does not require absorption from the GI tract. It increases the iron stores and availability faster compared to oral iron. The cons are that, of course, the patient has to go to the clinic or the dialysis unit, and these cause anaphylactic reactions, and it is expensive. Of course, whenever there is active infection, we should not be giving iron supplementation in any form, either oral or IV. So which one is better, oral iron or IV iron? So studies have shown that increased hemoglobin, increased ferritin, increased TSAT values, and reduced requirement of ESA has been proven with IV iron compared to oral iron in CKD patients, and also those who are on dialysis, especially those who are on dialysis, IV iron is always better. So this is a FIND CKD study where they compared IV ferric carboxymaltose with oral iron. So this was conducted across 20 countries, open labeled RCT among CKD patients not on dialysis with iron deficiency anemia. And you can see that the hemoglobin increase of more than 1 gram per deciliter is 56.9% in patients taking IV ferric carboxymaltose versus 32% only in oral iron. And adverse effects are similar in both the groups. So compared with oral iron, IV ferric carboxymaltose targeting a ferritin of 400 to 600 quickly reached and maintained the hemoglobin level. So this is another study, that is the pivotal study, which looked at reactive iron treatment versus proactive iron treatment. So this was conducted in UK, a multi-center RCT in patients undergoing dialysis. So patients with ferritin of less than 400 and TSAT of less than 30%, that is iron deficiency anemia, were recruited for the study. So the reactive group received 400 milligrams of IV iron sucrose monthly. It was given only if the ferritin was less than 200 and TSAT was less than 20%. In the proactive group, monthly IV iron sucrose of 400 milligrams was routinely administered. It was withheld only if the ferritin was more than 700 and TSAT was more than 40%. So you can see that the primary composite endpoint was much lower in the proactive group, that is heart failure, death, non-fatal MI, non-fatal stroke was much lower in the proactive group. The median monthly requirement of ESA dose was also lesser in the proactive group, and the rate of infection was similar between both the groups. So among patients undergoing hemodialysis, a high dose IV iron regimen administered proactively was found to be superior to a low dose regimen administered reactively. So what does the KDIGO guidelines say? It says that you have to target a TSAT of 30% and ferritin of 500. And before starting erythropoietin, make sure that you have replenished the iron stores, and you have also ruled out any other causes for anemia. Iron status should be measured every month in the initial phase of ESA treatment, followed by a 3-monthly interval. Now coming to erythropoietin, history of erythropoietin. Throughout the 1940s and 1950s, experiments by Krumdiak et al. Pointed to a protein in the plasma that increased RBC production. In 1957, Jacobson et al. Demonstrated that the kidney produced erythropoietin. In 1977, human erythropoietin was extracted from the urine of patients with anemia. In 1983, human erythropoietin gene was successfully cloned. In 1989, recombinant erythropoietin was approved by the FDA for use. And in 2090, Nobel Prize for Physiology and Medicine was awarded for their seminal discovery of hypoxia-inducible factor pathway. So coming to the advantages and disadvantages of erythropoiesis stimulating agents, the benefits are that it causes improvement in hemoglobin, resulting in better quality of life, fewer blood transfusions, and less left ventricular hypertrophy. The risks are increase in hypertension, malignancy, thromboembolic events, vascular access thrombosis, cardiovascular, and all-cause mortality. So we should always balance risk versus benefit ratio whenever we are administering erythropoietin stimulating agents. Now, what is the target hemoglobin that should be maintained in patients with CKD? So for this, there are a number of trials: the normal hematocrit trial, the COIR, CREATE, and the TREAT trial. So if you look at normal hematocrit trial, this was in dialysis patients. Target hemoglobin were 10 versus 14. So they found that time to death of first myocardial infarction was much higher in the 14 grams per deciliter group compared to the lower hemoglobin target group. Similar results from COIR as well. This was in CKD patients. COIR, CREATE, TREAT, all three in CKD patients but not on dialysis. For COIR, the two groups were 13.5 versus 11.3. And they found that higher hemoglobin target of 13.5 was associated with death, myocardial infarction, hospitalization for chronic heart failure, and stroke. Similarly, with CREATE, a hemoglobin of more than 13 was associated with time to first cardiovascular event, though the results were not statistically significant. And for TREAT, there was higher rates of stroke and malignancy associated mortality in patients with hemoglobin of more than 13. So based on all these trials, the target hemoglobin as advised by KDIGO is between 10 to 11.5 in patients who are undergoing dialysis. So erythropoietin alpha was the first FDA approved drug. The dosage, as you can see, is 100 units per kg, 1 to 3 times per week. So the frequency given per week is much higher. So that is exactly why darbepoetin alpha formulation was prepared. This is hyperglycosylated preparation. So as you can see, you can administer darbepoetin alpha once every 2 weeks. It is 0.75 micrograms per kg once every 2 weeks. Then following this, pegylated form of epoetin beta was introduced, that is methoxy polyethylene glycol epoetin beta. So this can be administered once a month. So this is our molecule of interest for today. Now, what is pegylation? Pegylation is the covalent coupling of non-toxic hydrophilic polyethylene glycol to active pharmaceutical ingredients such as proteins, peptides, antibodies, colloids, etc. And this is a time-tested concept. How does it work? It increases the size to reduce kidney filtration. It increases the solubility because the PEG is hydrophilic, and it also decreases the accessibility for proteolytic enzymes and antibodies. So, pegylation improves drug solubility and stability. It extends circulating life, enhances protection from proteolytic degradation, reduces dosage frequency without reducing efficacy with potentially reduced toxicity. Now, this is one study which was conducted in CKD patients who were not on dialysis. Here, Sera is nothing but continuous erythropoietin receptor agonist, was given once every 4 weeks, and compared to darbepoetin alpha, which was administered once in 2 weeks. So coming to the results of the study, so you can see that the response rate was similar in between both the groups, that is the darbepoetin group and the Sera group. So the response rate was defined as an increase in hemoglobin of 1 grams per deciliter compared to baseline, or achieving a hemoglobin target of 10 grams per deciliter. If you look at the mean change in hemoglobin, both the groups were identical or somewhat similar. So the study showed that Sera administered once a month was non-inferior to darbepoetin alpha, which was administered once every 2 weeks. So the conclusion was that Sera administered once every 4th weekly was safely and effectively corrected anemia in ESA naive patients with CKD not on dialysis, with a smooth and steady increase in hemoglobin. Fewer patients had hemoglobin levels exceeding the target, and Sera can be safely administered in all patients with chronic kidney disease from initial correction through maintenance. Now coming to patients who are on dialysis. So this is a Patronus study where they looked at Sera versus darbepoetin alpha in patients who are on dialysis. So this was a study design. This was open label randomized multi-center parallel group study, a total of 490 patients randomized from 82 centers across 13 countries. So you can see here that they are administering pegylated EPO or Sera once a month and darbepoetin alpha once a month. So if you give darbepoetin alpha once a month, you can see that the efficacy is not very good. The response rate is much better with pegylated EPO compared to darbepoetin alpha given once a month. So once a month pegylated EPO exhibited a superior response rate compared to once monthly darbepoetin alpha. Also, if you see only once monthly pegylated EPO maintained hemoglobin levels during the 26-week maintenance period as well. You can see that in the maintenance period, the DARBA group is falling down. The hemoglobin levels in the DARBA group is falling down, whereas in the EPO pegylated EPO group, it is remaining steady. So the safety findings were similar between both the groups. The treatment with pegylated EPO is superior to darbepoetin alpha when administered IV once every 4 weeks for maintaining hemoglobin concentration. Now, what does the KDIGO guidelines say? It suggests considering ESA use only if hemoglobin is less than 10 grams per deciliter. But before that, you have to address all potentially correctable etiologies of anemia before ESA use, including repleting iron stores if iron deficient. The levels to be maintained are between 10 and 11.5 in patients on dialysis treated with ESA. As we all know, ESA leads to excessive cardiovascular and stroke risk, so it is important to use the lowest dose possible to achieve the desired hemoglobin level. Moreover, when ESA hyporesponsiveness develops, reducing the cumulative dose is paramount. Now, why are we avoiding blood transfusion in patients with CKD? So, if the patient with CKD wants to go in for transplant, then the chances of alloantibody formation is much higher. HLA sensitization happens, graft failure, delay in transplantation, blood transfusion causes volume overload in already volume overloaded patients who are on dialysis. It can cause immediate hypersensitivity reactions, acute and delayed transfusion reactions, transfusion-associated lung injury, graft versus host disease, and transmission of infection. So we now have novel agents, that is the HIF stabilizers, hypoxia-inducible factor stabilizers. So what happens is in conditions of normoxia, the HIF alpha undergoes prolyl hydroxylation and it is degraded by the proteasome. Whereas in conditions of hypoxia, HIF alpha combines with HIF beta. It forms heterodimer, translocates to the nucleus, and transcription of all the genes that are involved in erythropoiesis happens. So because of which there is endogenous secretion of erythropoietin. There is increase in levels of erythropoietin, EPO receptor, hepcidin levels are reduced, transferrin and transferrin receptors are increased. So this is the new drug class, that is hypoxia-inducible factor stabilizers, that is prolyl hydroxylase inhibitors. So this inhibition of prolyl hydroxylation prevents the proteasomal degradation of HIF alpha. This creates a pseudo-hypoxic environment. So because of the pseudo-hypoxic environment, there is the HIF alpha and beta combines together, the gene transcription happens, there is increase in erythropoietin, transferrin receptor gene transcription. This stimulates EPO synthesis, improves iron absorption, improves mobilization of storage iron, and also reduces hepcidin levels. So what are the drugs that are available in the market? We have roxadustat, vadadustat, daprodustat, molidustat, and desidustat in India. So the disadvantage is that it increases the risk of pulmonary artery hypertension, causes tumor progression, thromboembolic disease. In someone with ADPKD, the cyst growth can increase. It has pro-angiogenic effects in patients with vascular retinopathy, such as those with proliferative diabetic retinopathy, and also increases the chances of vascular calcification. So if you see roxadustat, the MACE effects were much higher. That is, the major adverse cardiovascular events were higher in roxadustat. So it was not approved by FDA. FDA wanted more studies. Vadadustat and daprodustat has been approved by the FDA in patients who are undergoing dialysis. Molidustat and arodustat is approved in Japan. Desidustat has been approved in India for use. So you can see these drug formulations, you can see that some of them are undergoing trial in US, some in Europe, some in Japan, some in India. The dosages are different, the half-life is different, the metabolism is different, and the relative activity is also different. So there is difference in study design and study conduct. There's also differences in biochemistry and pharmacological characteristics between the drugs. Vadadustat is supposed to be hepatotoxic, so FDA has issued a warning that you have to check for LFTs when you're starting someone on vadadustat. So the key points from this seminar are that you should always correct reversible causes before you start using erythropoietin stimulating agents. Monitor hemoglobin, iron status, blood pressure, and response to erythropoietin regularly. Treatment individualization is very important. You have to balance benefit versus cardiovascular risk in someone whom you're initiating on erythropoietin. Thank you.